Welcome, Erik. We're so delighted to have you back again for our final year of broadcasting at World Massage Conference.
I can't believe it's the last year, 11 years.
It's been 11 years, and we really appreciate all your contributions over the years. It's been great information, and we're expecting a great presentation today as well. No pressure at all.
No
Um,
question.
and our topic is basically solving unsolvable pain problems. And sometimes therapists get these clients in their rooms. They've worked with them for ages, and it just doesn't seem like they can make any progress. They might reach a certain level and then they plateau, and they just can't seem to get the problem resolved. And sometimes it's not that it actually is unsolvable, but
Yes,
maybe the
right,
approach has to be a little bit different.
right.
And so we're bringing you in here to share your unique approach, which is myoskeletal alignment techniques, and how you would go about treating a problem that seems very difficult to get progress on. And today we're actually going to be looking at a real client who's actually a massage therapist, and you're going to be working on her. Her name is Dina with Paul Kelly. So we're excited
Right.
to see that. Now, before we get into the techniques part of it, maybe you could tell us a little bit about myoskeletal alignment techniques. Can you give us a quick summary of what that approach is?
I used to hate this question when people would ask me about roofing. When I first moved to Oklahoma from California in '84, brought my roofing practice to Oklahoma. They would call on the phone and say, "You do roofing?" "Yeah, I mean a good roofer." And then they would ask me to describe roofing, and it was always hard to do in a paragraph. Basically, when I developed myoskeletal alignment techniques, or MAT, in the mid-'90s, it began as a combination of myofascial from roofing and skeletal work from my studies at Michigan State College of Osteopathic Medicine. So, thus the term myoskeletal, or as you guys in Canada say myoskeletal.
I've been trying not to say that for you.
But that's constantly evolving, like everybody else should be doing. So we now include nerve mobilization techniques, corrective exercises. Paul Kelly's brought some nice corrective exercises in from his Temple Human Performance Center in Knoxville. New concepts in pain science from San Diego Pain Summit conferences, which I encourage you guys to attend every year in February. But basically what MAT practitioners do is we take clients through a series of deep tissue and graded exposure stretching maneuvers that help calm hyperexcited nerve receptors, and we deal with things like abnormal head riding reflexes and revert and radicular type pains. And then we use specialized corrective exercises to help downgrade some of the protective muscle guarding that some of those head riding reflexes have caused. So the basic bottom line to MAT is that it's based on keen observation and compassion skills, and it's guided by the principle that the healer is ultimately within each client. We're the facilitators. We're not healers. And so if you keep that in mind, then you're just working together to get great results.
Okay, that was a fantastic summary.
You thought so?
I thought so. You get an A plus.
Thank you.
And we'll get a better sense for what that means in concrete ways once we start looking at the work you're doing on Dana. Now you've talked a little bit about the origins of your work. Did you want to add anything about sort of the influences on the development of the work?
Yeah, myoskeletal basically is influenced by legendary figures such as Ida Rolf, the late great Dr. Philip Greenman up there. Well, do you have a question about her?
Yeah, and that's really where you started, right? You didn't start as a massage therapist. You met Ida Rolf, and you met Ida Rolf sort of accidentally.
Right. Went to massage school to become a Rolfer. I got, like most people back in the late '70s, something happened that changed your life. Somebody, in my case, I was a drummer sitting in the studio hitting pounded 2 and 4 and had a real bad scapular problem that nobody in LA could fix. And this Rolfer fixed my pain, and that's what got me interested. And it's been a wonderful 30-something years since then. Also, people like Serge Grakovetsky, the spinal engine guy, Moshe Feldenkrais, of course, Vladimir Yonda, I met up at Michigan State, upper and lower cross guy. and movement gurus such as Gray Cook and pain science leaders such as Lorimer Mosley and David Butler, and then my idol from Stanford neuroscientist Robert Sapolsky. So we all stand on the shoulders of giants, and I've certainly been fortunate to study with some of the very best, I think.
Yeah, and these are names that are not necessarily easily recognized by massage therapists, but these are really pioneers in the area of physical medicine, from various types of approaches.
Right. Yeah. Well, I love a little bit of everything. I started out in psychology, my background was psychology, and didn't do very well in that. I was very, I didn't like listening to people whine all day. So once you can put your hands on them, you still can use your psychology, but you're not responsible for what you say necessarily. Not as responsible.
Now let's dive into the actual approach itself, or the techniques. Now, I know that before you start any treatment, you use what you call touch tools. Can you briefly describe what you're doing with touch tools and why you do this?
Yeah, now in workshops, we often start with that segment, touch tools, and basically it's no goals. All we're doing is allowing the therapist to practice proper body mechanics and experiment with various hands, elbow, fist maneuvers, and things like that. We noticed in workshops, we do 3-day workshops primarily, and we noticed we couldn't figure out why the people were so much better day 3 than they were day 1. And then we realized that, you know what, it's not what we're teaching them, it's that the body mechanics that we keep emphasizing throughout the days are starting to take effect, and people are using their body better, and that's why they're looking better. Their treatments are looking better, they're looking more comfortable, they're more relaxed. So that's what Touch Tools does. It gives them a chance to get comfortable with manipulating various tissues and also connecting with their partners.
Yeah, as well as warming up the client's body.
Right. Yeah.
Now let's take a look at some of these in use. This is we'll show a clip from an ABMP event you did, and you're going through a variety of these touch tools, not all of them, but a sampling of them so people can get a sense of them. And I want to encourage anyone that's watching, if you have a table set up and you have somebody nearby, grab them, throw them on the table, and follow along. Okay, here is an introduction to touch tools.
We're going to start today with a thing called touch tools. We're going to go through all of the body mechanics that a lot of you already use, and some people are more proficient at body mechanics than others. And so we noticed in workshops that day 3, the people are much more proficient. We've always wondered why they get better. And of course, obviously they get better because they're learning the techniques, more familiar with their partner and things like that. But one of the things that we've found is the most important part is they start understanding how to use their body mechanics better. That's been, people have been writing about that and talking about that for a long time. We talk about it all the time in myoskeletal, and that's something that we're going to focus on today. We're not going to talk about why we're doing these techniques. You guys are going to be following me through a series of 13 simple routines, but we're going to be talking mainly about why we're using our hands, fingers, arms, elbows in certain ways. Okay, so if we could get my model in here, Nick. Welcome, Nick. Thank you, buddy. Take the shirt off, please. If we could get your people prone. Everybody on your partner's left side. And we're going to do some random techniques, some of them that we use in myoskeletal to just kind of warm up the tissue. In this first one, we're going to be pumping the legs, some of the fluid, and getting everything going, moving up the kinetic chain from the legs. Our right hand will go on your partner's left leg, and we're going to pull the gastroc soleus kind of toward you. Kind of pull it toward you, and the left hand's going to be a fist, not a firm fist, but a soft, flat fist, and it's going to go up on the hamstrings. And you're going to first thing I want you to do is just take your body weight and lean it into this left hand. That's the pin hand. That's the one that's really going to be doing the work. We're going to pin there, and then we're going to twist this at the same time. So we lean in. So it's a whole body maneuver. That looks good. Lunge stance. That's good. We're just leaning in and kind of twisting the tissue. At your own speed. You'll find that you and your partner will develop your own rhythm, and that's the whole idea, is to get those brains, those critter brains, that limbic system brain, working together with your partner, depending on what they're coming in with. Some people come in with an old sciatic problem, and you start to do this technique, and they start jumping. The brain still thinks there's a problem in the hamstrings or gastroc or something like that, so you have to slow down. All right, so anyway, that's the basic idea behind that. Let's come up here and, well, first of all, just put this knee 90-90. Put it to 90-90 like this. Take the web of your right hand, my dominant hands. Anybody left-handed in this group? All righties? Good. All righties. Left hand's going to come in like this. They're both on top of medial malleoli up here, all right? Get your body weight low. Elbows out. And then we're just going to keep this real firm to our body. Get it move the leg a little bit closer to your body if you can. Good. And then let's just twist it like this. Lift it a little bit and then just twist. We're just kind of mobilizing this ankle, trying to feel for art, asymmetry. Of course, the body isn't completely symmetrical. We never will try to make it symmetrical, but you can compare it side to side and see what their genetics is like side to side. Asymmetry, restriction of motion. Is there more restriction in one direction than the other, or leg to leg, foot to foot? Tissue texture abnormality. Is there some funky muscle spasm going on? Fibrosis, any kind of old scar tissue type things from ankle injuries, particularly something like this. Stop. Grab the ball of the foot like this. And I just want you to sling that ankle away like that, right? Sling it away. Very good. Okay, take this hand, put it up on the gastroc soleus again, anywhere you want here. What we're going to do, we're going to be doing a lot of this today. This is sling and resist, S&R. And we're going to throw it away, and at the same time, we're going to resist with these fingers, with these soft fingers. But first of all, I want to get the body right. I want us to get down, lunge stance, lumbar lordosis locked in, and then sling it and resist. And then adjust your body weight accordingly, and you can move around. Yeah, there you go. Okay, you can really get going on this if you want to. I mean, start out more slowly maybe and get going. This actually helps wake up the tissue. So all of your pre-sports massage people should be doing some of these, what we call spindle stim. It wakes up the dynamic gamma motor neuron of the muscle spindle. It helps stimulate some tone, particularly if the foot is in a little dorsiflexion. So you can go back and forth between mobilizing and sling and resist. Right into, that's good, Yeah, I like the elbows out there, that's good, Okay, look up here again. This time we're going to lean into the pin again. Let that left hand lean into the pin, and then just drop the leg. And let's just do a few pin and stretches. This time, what I'm trying to emphasize here is letting your body weight drop into the area of dysfunction, which may be hamstrings, may be an old hamstring injury or something like that. So that's what we're trying to do. A little pin and stretch. It's been around a long time. I love this technique. Looks good, Michelle. Stop. Let's go up here. One of the things that I think a lot of therapists are taught not to do, that I think is a huge mistake, is bone palpation, bony palpations. And I'm not talking about just identifying bony structures. I'm talking about actually scrubbing the bones. The periosteum of the bones is highly innervated, and the brain pays a lot of attention to the bones and the periosteum. So what we're going to do is we're going to actually put a palm of your dominant hand on the sacrum, the sacrum bone. and just kind of lean into that sacrum bone. Just lean into it. We don't want to be on gastroc. We don't want, I don't gastric. We don't want to be on glute max, any of the gluteals. All we want to do is palpate for the lateral sacral angle, it's called, but just picture the sacrum running at an oblique angle, and we're just going to now brace our non-dominant hand on top of our dominant hand. We're just going to kind of roll that bone. Just going to kind of roll that sacrum gently. Of course, it's all pain-free. You always keep a contact with your therapist, with your partner, particularly when they're prone, to make sure that that we're not getting any spots that they're uncomfortable with. So we just kind of roll that. That looks good. Get your body weight, lean into it a little bit. Come all the way to the end of the table if you can, where you can push this way. Can you do this? It may not allow you to do this because of your arm length. If not, you can move to other sides. In class we roll around, but for camera purposes we're not going to do that. But yeah. Just leaning in. Let your body weight lean into the tissue. Okay, stop. Come in here. I want to talk about the forearm thing one more time. Just bring this up briefly. That the flexor muscles typically in the upper body and lower body both always overpower the extensors. So our weak link in all body work, particularly when we're doing extended finger work, is the forearm. It's really not the fingers. A lot of people go in, like when we were at the Rolf Institute, one of the drills that we did were finger push-ups to get our fingers strong and extended when they're in an extended position. But really, that's not the problem. The problem is keeping these forearms firm. So first of all, I just want you to place your fingers on this person's back like this, like you're pushing this tissue. Find those little erectors, or the big erectors, and kind of scoop these erectors. And now all I want you to do is feel for tightening your forearm. Just tighten your forearm, firm them up. And now just lean your body weight with firm forearms. Keep those forearms firm. Don't think about anything else but the forearms right now. Nothing else but the forearms. This is very good exercise, and people love it, but it's an excellent way to learn to strengthen your extended fingers and strengthen your forearms by hooking the erectors and moving them toward the midline. I'm not going to talk about the biomechanics of that, but we may talk about that later. Now go to fists. Now we're going to go to fists, which are soft fists, obviously. They're not wadded up fists. And we're going to take both fists, get our body weight low again. There you go. Lean into them. Now stop. Don't move. All I want you to do is firm up your forearms, your extensor muscles in your forearms first. Just make them firm. Now move the body with those extended forearms firm. Okay? Yeah, that looks better, a lot better. All right, now come on up and keep your forearms firm, but move around a little bit on that tissue to see if you can still focus and keep the forearms firm while moving a little bit now. All right. That's good. We're going to be going over this all day long, so it's just a preface on that. Stop. Let's duck grip the neck here. What I want you to do is take your dominant hand here. This is just another little tool that we're going to go to. Sometimes is helpful in certain situations, and all massage therapists, body workers use this. But let's duck grip and then duck grip over our other hand, and then I want you to just step back. The difference in doing this, notice what I'm doing here. I'm working my flexor muscles by gripping and pinning. I'm not involving my shoulders, my back. Nothing's really working. I'm doing this. That's called the jiggling hand syndrome, and it's something that is very annoying to people on the table. So you've got to come in with a You know, their five senses are in there working the moment they come into your therapy room, and they're picking up all this information about you and how safe they are there, what kind of pain problems they may have, and how you're going to help them. And if you put your hands on them and you're not firm, if you're not coming from the ground, they're going to know it right away. So here with this duck grip, we're going to get, rather than coming out here, we're going to get right in the web. We're going to go way back here in the web of our hand and grasp first. You got that? Right hand, dominant hand down first with the web, and then come on top, and then just pull the whole tissue back as you step back. Pull it back as you step back, keeping your lumbar lordosis locked in. That's, pull it on the way out, Michelle. Pull it back on the way out. There you go. Great, feels good too. Nick snoring, is that you making that noise? Okay, let's see. Let's go to sideline. Let's see how we can do to get this on film. A lot of people don't use sideline techniques, and it's something that you got to integrate into your practice because there's so many things you can't do other than the sideline position. Okay, Nick, let's just get you on this side right here. So everybody's going to be lying on their left side, please. They can use their bolster there for their cradle there for their head. All right. For those of you who do not do sideline techniques, let you get in position there. First thing you do when you get them sidelining is what? Bend these knees up. Get these knees up so they won't roll over on you. A lot of people come into my practice and they'll, begging for work, and as soon as they get in a sideline position, what do? They roll over where you really have nothing. You can't get to them, And so what do? You put the arm behind them to help them come back. Anytime you want the people to be more upright, you can put the arm behind them. Some of these techniques we're going to do right now you won't be able to do this with. But right now on the upper traps, we're just going to get fists again. We're going to go with fists again, but we're going to think forearms, all right? And we're going to get our body weight low, and we're just going to scrub, do a little scrubbing on the upper traps or whatever. We're just practicing with our hands and body weight right now, body mechanics more than anything else right now. We're really not trying to, we have no goals. We have no postural goals or biomechanical goals right now. We're just simply practicing using nice, strong touch, developing a strong touch through these touch tools.
Okay, so that was an overview of touch tools. Again, not all the touch tools, but a little sampling of them so you get a sense of what that's like. Now we're going to look at one of the case studies that you do in your new Art of Mat program. And people can check that out on your site, erikdalton.com. And we're going to play an introductory video to that course. So let's just play that now, and then we'll talk about this case study and ask you some questions about it after we play this introductory video.
We're glad to be back again here after Motion is Lotion last year. We're back here trying to catch you up to date on some of the new things that we're going to be talking about. Paul and I want to go through this and our assessments and kind of give you a flyby on what's new and what is the same that is on some of our other DVDs. So Paul, talk about some of these, recognizing the compensations. What compensations are we talking about?
Well, we always go back to basics. You want to go to your anterior and posterior curves first. Well, that's Yonda. Yonda's been around for a long time. Erik introduced it to the massage therapy community a long time ago. Now we're seeing it in college textbooks. We're seeing it in men's health. We're seeing it everywhere, but that's where we start. Anterior, posterior curve. So the first one we like to look at is the upper cross. Erik, show them what the typical upper cross looks like.
Why me?
Because
he wants me to show the upper cross.
Because he should have more of it than I do, right?
Hey!
Okay. So there he's got an upper cross.
Upper cross.
So upper cross does a lot of things, and we have a formula that you've already seen probably in our other DVDs over and over and over again. But that's the upper cross is for the upper body, and then the lower cross is the opposite of that. It's just down from the lower body under. So we got the anterior tilt in the pelvis. We have the sway back. We have a lot of, we could have abdominal distension problems from that. There's a lot of things that come from lower cross problems. So that's where we start. And then we start to get a little more tricky and get into the common compensatory pattern.
Yep, these are in our upper body DVDs, and that was developed by Dr. J. Gordon Zink in 1975, actually. He measured hospitalized and healthy people. I think it was some unbelievable 1,700 or 17,000, I think.
Yeah,
people.
a lot of people.
And what he did is he checked the biases along the four major junctions. The four major junctions in our body are cervical cranial, which is kind of OA, AA, cervical thoracic, thoracolumbar, and lumbosacral. That's where the plane of the joints change, and that's where we get most of our dysfunction, is from those four junctions. We've got ascending and descending syndromes.
Yeah, ascending and descending syndromes. This could be something that could be a little confusing. This is kind of, where did the lesion originate from? Did it come from the ground up? We're talking about in gravity now. So if it's an ascending, it's obviously coming from the ground up. It could have been from maybe a one-legged stand, or maybe you stand on one leg all the time. Maybe you had an accident where you broke your femur or you broke your ankle or something, and you had to be on the crutches, and so you stood on the one side, and that started the ascending problem coming from the ground up, which went through the pelvis, which changes the cranium. So we know it's changing the base. So if we change the base first, we know it's an ascending, come from the ground up. If it's descending, maybe it started with the head. Maybe it was from right motor dominance, where you were in school, sitting in a chair, writing with a pen, with your head cocked one direction the whole time, starting this pattern. We're looking for patterns. Where did it start? Is it coming from the head working its way down?
TMJ.
TMJ. If the head's forward, we know that's an anterior-posterior problem with maybe a little bit of rotational pattern in there, like a right compensatory pattern. So we got X legs, valgus knees. So we see this more obviously in females than we do in men, but this is something we definitely want to address if we're looking for this. We can do a step-down test with females or males. It doesn't matter who we're doing with, to see if there's a collapse in the knee when you step down. If there's a collapse in that knee, what's weak? Abductors are weak. There could be other things that are weak too. Maybe QLs are weak too. But there's going to be a breakdown somewhere. If you have a lot of Q angle already, like in most female pelvises, you're going to have a little more of this X knee than you are in men. But you still see it in men with some low back dysfunction. And then you have Y legs. Well, what's a Y leg? Well, it's bow-leggedness, right? Michael Jordan's a prime example of bow-leggedness. Makes you really quick because it puts you on the outside of your feet. It really strengthens your abductors and makes your adductors tight. So we know that's an issue too. Puts you on your toes, makes you real quick. It's really great for a little while. But then it can cause some dysfunctions, not only in the ankles and the feet, but also in the hips. That's something we don't talk about, that acetabular, the size of the acetabulum, how deep is the acetabulum, and what does the neck look like on the femur? Does it fit in there? There's always these variances in the neck. Well, if you've got bow legs, it really pushes that head into the acetabulum in a different area. It can really grind and wear out that acetabulum and the cartilage, and also the labrum in there too. I've seen a lot of problems with the labrum. So that's something we definitely want to look at when we're treating these patterns.
We're going to be seeing some people today with both kinds of legs, the X legs and then the varus bow legs like he talked about, and then combinations. Just because we talk about these as if they're always femoral external rotation along with tibial external rotation, that isn't always so. Today in the videos we'll see some variations of that causes a shearing force across the knees that's very destructive. Remember, the knees are really a slave to the hips and the feet and ankles. So we've really got to correct above and below, and don't just go to the pain pattern. Always look for the patterns. Anterior spring system, posterior spring system, stirrup spring system, start and lateral spring system, all started by Andre Vliming. And I'm not going to go into each one of the particular muscle imbalance patterns, but I just will say that anterior spring system, it's causing these crossover patterns.
Yep.
In your scoliotics, you can't just go to the back. You've got to look at the patterns, look at the spring system. What is it coming? What are they coming through? So we're looking at still trying to look three-dimensionally at the body. The body is a circular system, and you have to look at it circularly. Is that a word?
We made it one.
That's a word.
Now we got it.
Okay, so lateral, we're not going to get into that. Right motor dominant, you want to talk about? Ross Pope had a lot to do with that.
Dr. Ross Pope is one of my favorite researchers on this right motor dominant pattern. He did clinical research on hospitalized patients, and I forget the number of it. It was another large number of patients he looked at. But he was looking for a common pattern, once again, looking for the common pattern in the body that he saw. And in our society, the most common pattern we see is a right motor dominance. So what does that mean? Usually it follows with a right eye dominance because right's motor and ears are vestibular. So it would mean that they were right eye, left vestibular. They balance on their left and they motor with the right. They kick with the right leg. They throw with the right arm. Well, that becomes a spiraling pattern that we're going to see in almost everybody. And one of the number one things I like to do when I'm treating somebody is I say to myself, prove to me I do not see this pattern.
Right.
I'm always looking for it. And if I don't find it, then it's usually odd because I normally see it in almost everybody.
Right.
And even in lefties, I'm a full left-handed person. I kick with my left, I throw with my left, but yet I still have a right motor dominant pattern in me. It's just really strange. And we think it comes from fetal development. He wrote an article, Erik wrote a really good article in his volume 1 advanced myoskeletal book on this fetal development, where we think it might come from the third trimester fetal eye, from the rotation in the fetus.
The Ida Rolf is talking about that. Pope, a bunch of people have talked about that and everything. But the main thing is that it's so much easier to look for patterns rather than just trying to piece everything together. Prove to me you're not upper cross. Prove to me you're not right motor dominant. Prove to me you do not have anterior spring system problems. Prove to me that the biggest movement dysfunction we have is the diaphragm. Our breathing, as Carol Lewitt says it best, is our most dysfunctional movement pattern is our breathing pattern. So anyway, we go through the spring systems and the motor dominant stuff, which is all really, really fun and easy to work with. And we get to scoliosis, which obviously is a three-dimensional pattern. We'll have people in showing you some scoliotics today. And doesn't necessarily have to be a terribly dysfunctional thing. Sometimes it's functional, sometimes it's structural. A lot of times it's fixable.
Remember, we're treating patterns, but when treating patterns, we still have to do a lot of assessments. So we just want to show you this assessment here real quick. And these are some of the things we're going to be talking about today on our DVD. So just to reiterate, patterns is the problem, but we want to do a lot of assessment to find the most significant lesion in the body. Where is that coming from? And then there's a lot of cool assessments that we can do standing and table side, where the client's laying prone or supine. So,
right, like this introductory assessment, mainly a lot of this is going to be as they come into the office, perform this stuff. They don't even have to get out of their clothes. I know if you're in a massage therapy format, and you usually leave the room draped. When they come in, take them through a few of these things and see where they're at with them. And then table assessments. You get them on the table and just pick out. I mean, obviously some of them you're not going to have to do. If they come in with a rotator cuff problem, you're not going to have to go through the Brugger test for headaches. You know what I mean? So in other words, this is going to be what we're going to be picking out and using on all of our people to come in. They were so gracious to come into Art Space, this beautiful place that we've leased, and we're very, very happy to be here. And I'm happy again to be with my dear friend, my old bro, Paul Kelly. I hope you guys have some fun today.
Okay, that was a good introduction to some of the approaches you take in MAT, or myoskeletal alignment techniques. I'm just curious, why the focus on compensations?
Paul and I worked a lot on common compensatory patterns we picked up from a osteopath here in town I used to work with, Dr. Ross Pope. A lot of things like brain dominance, right motor dominant patterns, and we start looking for patterns because when the brain senses instability or tissue damage in and around the spine or in other areas, information is compiled and fast-tracked to the brain. Brain makes a determination as to the degree of threat, and then appropriate action is handed down. Tightness is one of the ways that the brain applies the parking brakes, which is an article I just wrote in Massage and Bodywork magazine about applying the parking brakes. That's the naturalist body braking system, but when it fails, we get compensations or adaptations and sometimes pain. So when the body's healing mechanisms have been compromised, the nervous system has the ability to fully engage a parking brake to slow us down and keep us out of trouble, but unfortunately that sometimes leads to compensations. So that's what Paul and I were talking about in that introduction, is the different compensations that we go through during this Art of Mat video series.
And one of my takeaways from this introduction is you're not just looking at the actual lesion itself or the specific pain problem, but you're taking a more holistic view in terms of how do these other compensations in the body impact the treatment that you're going to do.
Right, yeah. Whole body, whole brain, everything is connected. We've got to look at but we just find it's a lot easier to look for patterns. In Walthing, we would sit in that outdoor mall there in Boulder on Pearl Street and watch people walk and try to assess each individual little movement, and that is ridiculously hard. Some people are excellent at it. Tom Myers, one of the best I've seen, but we look for patterns. Prove to me you don't have a right motor dominant pattern. Prove to me you don't have upper cross syndrome. Prove to me you don't have a spinal engine problem with altered cross pattern gait, things like that. And then if they don't, we move on to the next thing. Looking for patterns simplifies the assessment a lot.
Okay. Now let's look at a real client, and this one is a massage therapist, and I think the primary complaint is thoracic outlet syndrome.
Right.
And we're going to show a video to show the assessment process. Is there anything you want to say before we play the video about this particular therapist?
There's really no typical assessment in that. Every client or patient, however you want to call them, brings in a special set of body-mind circumstances, and we just try to watch and listen and be passionate, make them feel safe, and use good clinical reasoning skills. But we do look for strain patterns, and that's what we're doing with Dina here, who is a Ashiatsu bar therapist. She holds onto the bar, and that's where she's getting a lot of this shoulder girdle problems leading to her thoracic outlet stuff. So that's what we'll see here.
Okay, let's watch this assessment.
Dina joins us in this segment to demonstrate an unusual case of thoracic outlet syndrome. As Paul and I observe for dysfunctional patterns that may be causing Dina's problems, we first notice how hypertonicity in her arm flexors appears to be pulling her shoulder girdle forward, particularly on her right motor dominant side. So rather than performing a typical thoracic outlet routine, we decide to start with graded exposure stretching to relieve tension in her tight arm flexors. Since Dina also reports pain in the lower rib cage, particularly on forward bending, we next evaluate for protective muscle spasm, and we notice some lower thoracic rib compression. So here's what the assessment looks like. We've got Dina with us today. Dina's a client of mine, and she's an Ashiatsu bar specialist. So tell them what you do.
I do Ashiatsu Oriental bar therapy that I learned in Denver. I basically do massage therapy with my feet, and I hold on to two parallel bars that are mounted in my ceiling above my table.
Flexed arms. She's flexed a lot.
Tight, lots of tight forearms, some things going on in wrist, but mostly tight right in here. Use my body a lot of different ways, and that's about all I have to say for now.
And she takes good care of herself, and she's a compliant client, does the exercises and everything like that. The thing that I noticed with Dina that we have some problems with is that the arms do not like to come out into extension because she's doing this all day long in a flexed position. Notice this right one, how much more trouble she has going into arm extension. It just does not lay comfortably. It's not happy. What I want to show, a couple of things. Paul and I want to show a spinal problem that we want to deal with. But first of all, a lot of times when you're dealing with this kind of thing where she's got a little bit of a rotation of the shoulder here, kind of coming maybe across, and a little bit of upper cross coming across here. A lot of times what's pulling that down? What's pulling that shoulder down? The long head of the biceps. That tendon comes up here and starts pulling it down. So you want to enter the body. Sometimes you don't want to always just enter the body by coming in and opening the pec wall and the front line up. You want to come in and open the arm line up. Open the arms, the flexor lines. Remember, the flexors always overpower the extensors in the extremities. So we'll come in and open up this. We're going to open up the flexors and then come into the shoulder girdle. Allow this thing to roll back and correct some of this little bit of a rotational pattern that she's having. Actually, I would do it in both arms, but we're only going to demonstrate it in one. Turn around, Dina. All the way around. Okay, so look at this. This is my spine, except she's got a little better spine than mine. Look where things are going in a few different ways, but mainly we like for the apex of the lordotic curve to be at L4. L4, L3, okay. L3 is okay, but we really like L4. We don't like T12, L1 to be the apex of the lordotic curve. because what's happening, these joints are stuck together. Picture it. Lumbar curve having to butt up against a kyphotic curve is causing jamming of those joints there, and it can cause all sorts of visceral type problems, ovary things, a bunch of stuff like that. It can start affecting other branches of those nerves other than the spinal and motor nerves. Look at this. I don't know if you can catch this or not, Mark. Can you see that, how the spine wants to compensate by trying to come back into the kyphosis right here? And it's coming in pretty nicely, right, Paul?
Yeah, it is. And Eric's, right on that. So we know we have some thoracic rib cage mobility issues here, don't we? So that's going to be part of the upper cross too that she's experiencing with me. She said she was having some hand numbness and finger numbness too. So this is all part of that.
Bilateral.
Right. So this is all part of the same problem. So we do have a little bit of lower cross with a high lordosis, and we have some upper cross stuff that we're going to look at here.
How close is this to a typical assessment? Are there other parts of this that you would normally do? I know this is done strictly as an educational tool in this video.
Yes. We had already assessed Dina. Actually, she was also a model in my Treating Trapped Nerves series too. And because she has quite a few neurogenic problems. And so, and her job just keeps having to recur. But no, every assessment is different. I mean, we'd have certain things. We have a whole chart. I think you can see some of them. You really can't see. Yeah, back here.
Yeah.
There's some of these things that are assessments, introductory assessments. So we go through all of those and we outline those in our in this Artemat video. But we don't do assessments that obviously aren't needed. If there's people come in with neck pain, we're not going to be doing some sciatic assessment for for sciatic nerve entrapment.
Now, let's get into this first treatment video, this first segment. And you're taking an unconventional approach to thoracic outlet syndrome. And in this segment, you show how you're starting with the periphery instead of starting with the chest or neck like is typically done. So let's look at this, and then you can tell us a little bit more about that once we've seen that.
I begin this treatment section by opening Dina's palms with some of the techniques that we've learned in massage school. And then I work her forearms and begin making my way up her arm flexors to relieve some of the drag on the shoulder girdle. This is an excellent way to prep the tissue to relieve the possible nerve entrapment that Dina's been experiencing down her arms, particularly in the radial nerve dermatome. So let's take a look at those techniques. Dina's grabbing the bar. She's holding the bar, got flexion problems in her wrist. I'm having a hard time straightening these knuckles out. She's got flexion problems in her arm flexors, biceps, all the way up. Long head of biceps is pulling the shoulder girdle down on this side. So we're going to start like we did in massage school. Remember, this is how we open up the palm and everything in massage school. Start by doing that. But now what we're really going to want to do here, I'm just going to use that hand grip to come in with my forearm. Typically, I'll sit on the table where I can brace the arm like that. But for camera purposes, I'm just going to come up like this. Traction. And then sweep down the forearm.
Remember, the body will sacrifice its complex movement for stability. That's something to be remembered, and it does it really a whole lot when you see people that grip things all the time, like golfers. Anybody who's grabbing and holding things, you'll see that quite a bit. Very fibrotic forearms.
So we're coming in and doing the same thing. Now as I come into her biceps, I'm going to externally rotate, which is where she does not want to go into the restrictive barrier. Notice how typically we have our fists like that. Use your fist in the vertical direction like this. You get a whole nother feel. So I'm going to do it with my thumb going the direction that I want to come. So I'm coming up.
Notice he's adding that little twist in there, the tangential force. Remember, we talked about that in the Vancouver Congress, the Fascial Congress. Muscle likes the tangential force, not stripping, but coming across the belly.
45-degree angle, externally rotating, opening the palm at the same time, all the way down. I like to put it, like I say, seated on my forearm, because you can get a lot better grip. Start with your ulnar bone, with your palm up. As soon as you hook the fascia, start to roll your flexor fascia on their flexor fascia.
Right.
That gives you a nice strong grip. That starts to open this up so that it starts to pull that down.
Okay, so that was the first part of your treatment on Dina. Next, we're going to look at nerve mobilization in the next clip. Can you outline what nerve mobilization looks like and why you do it? For example, the indications and the effects.
Yeah, there are different kinds of pain, referred pain, and we used to talk a lot about trigger point type referral patterns and stuff like that. That really hasn't panned out to be necessarily evidence-based anymore, but we do have radicular symptoms, and those things follow pretty much specific dermatomes. But the nervous system is just like the muscular system, fascial system. Everything's supposed to glide, and when nerves become entrapped from short tissues, short tight tissues, it can be in joints, other soft tissue areas. We get things like in thoracic outlet, people have to get up in the middle of the night and sling their arms out because they're numb, completely numb, or sharp pain, diffuse pain, all sorts of pain from nerves. And I took a workshop with David Butler, one of the founders, or really the guy who kind of sophisticated neuromobilization, and I didn't really use it, and it was a big mistake. I took a workshop in the 90s, and I always regretted not integrating that until I just did treating trapped nerves, because everybody should pay attention to nerve entrapments. Because when you're stretching somebody, when you're doing an Aaron Mattes ASI stretching, you're really, a lot of the results that you're getting is not from stretching muscles, or it's a lot of it is from the mobilization of the nervous system that you're doing.
Yeah, and that's so true. It's we tend as massage therapists to focus on muscles, fascia, and we don't realize the other tissues we're affecting as we're going through these procedures. So let's look at that video now.
This is much more specific. For different nerves going down the arm, you have to put things in specific positions to isolate, and so that's what we're doing here with Dina. She has a radial nerve mobilization problem.
Okay, so we'll look at that specifically, the specific positioning as you do as you do the nerve mobilization. Okay, so let's roll that video now.
Now that I've prepped the arm line tissue and relieved pressure on the shoulder girdle, it's time to lift the pectoralis minor muscle off the rib cage to help relieve brachial plexus compression and possible radial nerve entrapment that's been causing tingling and nocturnal numbness in Dina's arms. This time I'm going to come in with the my fingers flat against Dina's chest wall, ribs 3, 4, and 5, pec minor, and I'm going to bring it into a little bit of arm abduction, gliding along the border of pec minor. At the same time, I'm wanting her to turn her head left, and I'm wanting to take this thumb and push it out and stretch like that. Why am I doing that? Why am I having her turn her head? Go back straight. Go left again. Straight and left. Why am I doing that? Why am I pulling on this thumb? Thumb and index finger, radial nerve. The most common problem that you're going to see down the arms is a radial nerve problem. It sits on the bottom of the brachial plexus, and it's the most commonly involved. So you're getting the index finger and the thumb. So if you take the index finger and thumb and put in a little bit of extra stretch on them, while you come out here, you're getting a good nerve mobilization. So we're getting nerve mobilization for these tingling fingers that she's having, plus I'm getting a little pec minor. So it's good. As she turns her head left, gives it a little bit more pull on that nerve, and I would do this to both sides since she's having tingling in both sides.
Now, you often talk about nerve mobilization in your work, but you also talk about nerve flossing. What is nerve flossing, and how is it different than nerve mobilization?
It is nerve mobilization, nerve gliding, nerve mobilization, and there's nerve tractioning. We're pulling at both ends. Basically, flossing is like flossing your teeth,
Going back and forth.
So you put the person in certain positions, and for instance, if you're doing, in Dina's case, where we're working the thoracic outlet area, we use side bending so that when she side bends her head to the left, it's pulling all of the brachial plexus up toward her headward. And so then I will do a maneuver below that pulls the nerve bundle toward me. And so she'll go her way and I'll back off, and then she comes back to neutral and I increase. So it's just a flossing back and forth. And a lot of people do it in a bunch of different ways, and they just apply it in different ways. This particular nerve gliding for the radial nerve that I do on Dina is not the one that I teach in workshops. It's just one where I combine soft tissue work, working in her armpit, with getting some of the soft tissue tightness out of there, because she had some unbelievable subscapularis contractures in there. So I was trying to do two things at once in this one, but it's not typically how I do a radial nerve mobilization technique. But yeah, you just got to, nerves have to move just like everything else, and we're doing it all the time. Like you say, we're doing it all the time when we work on people, and we just don't know why we're getting some of the great results that we get.
Okay. So in terms of nerve mobilization, it sounds like there's sort of two categories of sort of mobilization: the traction, where you're putting a stretch on it or pull on it, and then the flossing, where it moves back and forth, under the underlying tissues.
Mm-hmm.
Now, like the use of touch tools that we saw at the beginning, you often use movement to mobilize soft tissues. So let's look at this next video segment, and I'll get you to comment on that after we've seen it.
To relieve some of Dina's thoracic and lumbar spine pain, I place her in a right side lying position with her top knee flexed so I can use my body to increase hip flexion. Hip flexion causes the inferior vertebra to open on their neighbors, and this provides relief for those joints that may be stuck closed. Here's what this technique looks like. Okay, we're going to get Dina on this side to deal with this problem that we saw here. So let's get your legs like this. And I'm going to want to see if I can, before Paul gets in here and gets his fascia fixed, I want to just see if I can get a little bit of opening at this T12L1. You do not want those joints jammed together. So I'm going to get her like this with my her knee against my body, and I'm going to hip flex her like this. Her hip's going to come down like this, which is going to ask the joints to open from below. It's going to pull the sacrum and all these joints open from below, and I am going to get on the superior vertebra and resist that. So I'm up here on the superior vertebra, but watch what I'm doing to the hips. It's posteriorly rotating the hips. It's coming back like this, and at the same time, I'm grabbing the bottom vertebra now and dragging the bottom vertebra with me. That's the T12. L1. It feels like it's actually L1, L2. So I'm dragging L2 down away from L1. It's not T12L1, which is the more common area. Just get that open. I do it bilaterally. Can you feel that right there? Mm-hmm. It's actually 3 segments, which is kind of what we saw when we looked at her. It looked like a little bit of a train wreck going down that lumbar spine.
Okay, that looks fantastic. Is there anything you want to add to that? And in particular, do you want to comment on your body use? It looks like you're very aware of the way that you're using your body to minimize strain, and that's something we saw in the touch tools as well.
Yeah, in this particular technique, you really have to, because as I recall, the technique I have Dina lying on the right side and her knee and hip flexed, and that allows me to get my body in there so that I can use my body to introduce a little bit more hip flexion. Then I come around with my right hand and help posteriorly rotate Dina's pelvis, which kind of tries to open the facet joints and get rid of some protective guarding that's causing tightness in her low back, lower thoracic spine, and upper upper lumbar spine. So yeah, as I lean into her, I've got to keep my body up or it's gonna wreak havoc with my own back. So I try to get in there real nice and close and keep upright, get the chest up, and then try to relieve some of that compression in Dina's lumbar area.
And you're still actively practicing, isn't that right?
Oh yeah, I still have
and so
down to 3 days a week though. It's a smaller practice.
And
I try to spend in Costa Rica now, and so yeah.
And how long have you been practicing?
Since '79, massage school in '79.
Okay, so that's a while. So it's
Well, I thought I would be, at least half a year retired right now. And the hardest thing that I've ever been able to do is to give up my clients. I mean, they're family. I work on every member of the family, and I book a year out. When I get my book in October, by the end of October, my next year is completely booked, and then I get people to get new people in. I have a waiting list, and if people don't want to come in for any reason or they're feeling good, I just have them cancel and put somebody else in. But no, it's tough leaving the family. So.
Absolutely. After working with someone for decades, you've seen them through every aspect of their life and really developed close relationships with them.
They're not the only friends I have anymore.
But to have that kind of longevity, you really need to be able to use your body well.
But we're kind of I'm an isolationist, really. I'm actually kind of like a Johnny Carson syndrome. I'm kind of basically very shy, and I like the reclusive life. I could be a hermit. You could drop me off on an island, and that's just my personality. But we don't need to go there, do we, Eric?
No, but we can go to the next segment, where you are working at relieving some protective muscle guarding in Dina's back, and so you're moving into treating the lower back by addressing some of the joint dysfunction. Now, is there anything you want to say to set this clip up, or should we just play it?
Paul, this is Paul's video clip, right?
Yeah, so we get to see Paul in this video.
Just one thing I want to say about this one. Paul, notice how it has her in what's called a Sphinx position. So she's in extension with her arms prone prop. She has to allow her belly to get soft to put the spine in extension. Now, if that causes any sort of pain, you got to get them out of that, because you don't want anything that causes. Not many people will have pain, but some people just putting them in that Sphinx position doesn't work. Got to put them back to neutral. But it's a great position if you can use it, because as he goes down into the lamina groove, it helps relieve some of the guarding in the multifidus and the longissimus and some of the little rotatories and stuff like that, and it helps help facet joints that aren't wanting to glide down on their inferior neighbor's clothes. So that's what this technique does, and I think he does a little bit of compression work just to get some mobilization in the thoracic rib cage.
Okay, so let's watch that clip right now.
The last technique addressed Dina's upper lumbar spinal joints that were not opening. To help keep the joints mobile, Paul now performs a soft tissue technique with extended fingers to move the erectors that are bunched up in the spinal groove away from and out of the midline. Paul then assesses and corrects a couple of problematic thoracic joints. Notice how handy the Sphinx position is for encouraging the superior vertebra to glide down on their inferior neighbors. Of course, you would not want to use this position on those with bilateral leg pain for fear of a possible undiagnosed spondylolisthesis. If possible, follow along with this routine with the partner.
If you take a look at this right here, you'll see, actually, you can see this on her where it actually dips off. You'll see it coming here. It's like T7, T8, T9, and then around T12, T11, you see it disappear. You don't see the spinous process. It's really buried and deep. So what we want to do is dig this out. This is a concavity. We don't want that. We want to let the lordosis come back to us just a little bit. So we do want to come at about a 45-degree angle. Remember to come off the spinous process and just dig it out like a little ice cream scooper and scoop it out and use the fingertips. Don't remember the old technique on just using those fingertips. Try to strengthen your extensors. This is a great way to do it. Just extend your fingertips and dig that stuff out of the groove. Move it out at a 45-degree angle and create some space for her spine to come back. I see people do this too quick. They're too fast. You got to go slow. You got to get underneath the wires. You'll feel the guide wires. They feel like little Tootsie Rolls, dehydrated fibers. You got to get under those and then dig them out. It's not super fast. It's not this. It's get under them and let them release and push them out at a 45. Don't forget that. You can't bully your way through this stuff.
Everywhere you see the sausages, when you see the sausages on each side of the spine, that's iliocostalis, longissimus, wadded up right on top of spinalis.
Right, and it should be really red and flush when you get done here. Remember what happens with pressure. We talked about it at the Vancouver Congress. You got pressure on the body, what's it releasing? Nitrous oxide, right? Vasodilators. We want that to happen. We want a lot of new oxygen to come in. We want all the inflammatory proteins, if there is any, to be moved out. And we also cause plasma extravasation. Remember that. It pushes the plasma. It hydrates the area. Hyaluronic acid. We talked about that in the book. Erik's written several articles on that. Okay, so I've done this for a little while. There's a Texas twister kind of thing that we can do. We know that this segment, as I kind of scanned down her spine just a second ago when I was feeling, and I felt a little bump along the road right over here on this right side on her. So we know there's fibrosis around here, and this joint's stuck open. So we also know that if it's stuck open, it's probably doing a little side bending, and it's also coming into some rotation. So I want to push that segment down, and I want to pull the other segment up. Because if this is side bent to the left and rotated, it's going to be up. So why not push it down where it's supposed to go? So I'm going to come in with the thenar eminence of my thumb pad right on that segment, and the opposite's going to be on the other side with the pinky side. And I'm just going to create a counterforce. You've seen a lot of people do this, but there's a reason why we're going in this direction. Because that's what the dysfunction's telling us. We've looked at the dysfunction, and this is what it's telling us. So we're going to take it in the pattern that it's not in, the pattern that we want to recreate and reactivate.
Yeah,
So
the knot was not there. When I had her in flexion, it was not there. As soon as we put her in extension and then we put her in the Sphinx
yeah, we're going to put her in the Sphinx here in a second.
We'll be able to see that.
So a few myofascial release technique here. She could take a deep breath in and she can pelvic tuck. That's another thing that we could do that helps to open up the segments and relax. Yep, that's real nice. I like what that did. Again, deep breath. Notice how it flattens out the lordosis when she takes that big breath and she exhales. Creates motion. Motion is the key. Let's put you in the Sphinx position now with your hands underneath your chin. This is a closing technique. So we put them in this position. It's asking these joints to do what? Close. And so we had a few segments that we're not closing. So you're going to come in. This is a flying V technique that Erik taught a long time ago. It's a really good one. It's kind of an awkward position to be in, but you can still get it to work. Extend your fingertips. Put a little bit of pressure on there. Have them do some pelvic tucking again. Yep. And relax. Good. And as she's doing that, puts a little stretch on the segment. And asking these joints to close. I'm applying pressure over top of the joints in the lamina groove. And we're asking those facet joints to close. Right here's where I feel it, so I'm going to spend some extra time right there on it.
She's going to look a lot better in this evaluation when we get her up. Remember that train wreck she had going on up
Back and
that
forth,
spine?
stack non-neutrals.
That's what they are exactly, stacked non-neutrals. That means one side bending one side, the one above it is side bending, rotating the opposite side. It's going back and forth. They're a little bit harder to fix than what they call type 1 group curves, where 3 vertebrae or more in a row side bend to one side and rotate to the opposite.
Good, so we've done that a few times now. Erik, you want to do anything else with that?
I just want to feel what you did. So the knot's gone that he was working on, so that's nice closure, and look how nice that looks. There's not a lot of that rippling going on that we saw a while ago.
Right.
Now we're going to move on to self-care or home care in what you call home retraining exercises. Now, do you want to comment at all on the role of home self-care as a way of augmenting your hands-on work and getting better outcomes before we show this clip?
One thing I talk about in workshops is you can't give clients too many things to do. They just won't do it. So I typically will give my client 3 corrective exercises that they perform once or twice a day. And then when they return for the next visit, I ask them to show me the exercises. So this allows me to observe for the quality of movement, how they're performing it and seeing if they're improving, but it also lets them know if they better be practicing the corrective exercise because I'm going to be quizzing them. So it's just another little way to engage them. But, one of the things that any kind of movement is good. All movement is good, and no one has really been able to prove that isolated corrective exercise is any better than asking people to go out and swim or walk or do yoga, Pilates, anything like that. I encourage clients to engage in anything that's fun. If it's fun, it'll keep them engaged. The brain is novel stimuli. And personally, I'm a swimmer. I swim 6 days a week, and I have a thing I've developed called snorkel rehab, where I wear this really goofy snorkel mask and fins and hand paddles, and I have 10 rehab things that I go through with that. I love that. I also do mini trampoline every morning, and like all sorts of floor exercises. But I give my clients basically stuff that is fun for them to do, that they will do.
So any movement is good, but we're going to look at some specific exercise here in this video segment.
Now that we've corrected Dina's back dysfunction, it's time to teach her a wonderful corrective exercise I call the pelvic clock. This functional movement routine helps strengthen the deep core muscles while keeping the fast set joints mobile. Dina is instructed to begin by pivoting her hips from 12 to 6 a few times, and then from 3 to 9, never going into an area of pain. Paul and I observe for altered movement patterns and cue her if she drifts off course. This home retraining exercise is done for about 10 minutes every day to improve core stability. I learned this back from the late, great Dr. Philip Greenman at Michigan State way back in 1992, and I use it in practice but keep forgetting to teach it. You act as if there is a clock with 12 up here and 6 down at the pubic bone, lying on their belly here. And so what you do, you can do it with the legs flexed, the knees flexed, or you can do it with legs straight, doesn't really matter. But for people who have low back pain, this is excellent because you can give them different motions for them to do. The first and simplest thing that I would want Dina to do is for her to go to 12. So tuck to 12. So she's tucking 12, pulling the pubic bone at 6 is coming up, 12 is going down. Now go rock back and forth between 12 and 6.
So she's creating
This is
motion.
a real nice pelvic tilt, but watch what's happening. It's higher now. This is where we want her, where it wasn't closing up there high. Now we're asking it to close. And just keep it mobile because we pretty much got it straight right now. Okay, that's all good, but let's challenge it a little bit more. Let's see if you can go 3 to 9. So 3's here, 9's here. There you go. Now
Good.
try rotating it. There you go. So you do that, but they stop. Anything that causes pain, have them stop. Don't let them keep going into the pattern that's pain because it's just going to put some protective muscle guarding there. Okay, stop. Then what we want them to do is we want them eventually, not in one session or anything like that, we want them to start going around the clock. All the way around. 1, 2, 3, around the clock so that they've got this rotation. And it's not as easy as it looks. Try it at home. Try that, Dina. Yeah.
Almost like belly dancing.
Keep going. There you go. Yeah, you missed 7.
I missed 7?
You missed 7. There you
Okay.
go.
6.
Always late on 7.
There you go.
That feels weird.
That was 7. That's right. She passed up her restriction. Don't go into that painful 7 yet. Just go back when you have a painful one. Go back to 12 and 6, 3 to 9, then start working from there. Okay. All right. Appreciate Dina coming in and helping us out with this, and I hope that helps you feel better.
Okay, so that's an example of a home retraining exercise. Is there anything you'd like to add, just in general, to this whole treatment that you've done for Dina here? I know we haven't shown the whole treatment. Is there anything you'd like to add?
This pelvic clock exercise I learned at Michigan State from Dr. Greenman in 1992, and I found it to be one of the most profoundly therapeutic exercises for dealing with sensory motor amnesia, which is just muscles that have forgotten how to fire. in the lumbar pelvis and in the core. These micro movements really help the client's brain connect with the body in a unique way. And so I have those little Dalton clocks that we hand out in workshops so that they can put them on the client's belly, and I have them play like there's a marble in the middle and make the clock go from 12, roll the marble to 3 to 12, 9, back and forth and around the clock. So but not going into any painful barrier. But people will do that. Things like that people love. It's fun. They do it.
Fantastic. Now, all these clips of Dina are taken from your new Art of Mat course. I've had a chance to go through it, and I think I love this one out of all your courses. I like all your courses, of course, but this one I really enjoy, just because these are real clients, real pain problems. It's not theoretical. It's not conceptual. You're actually doing the work on people with these issues. So that's fantastic. But I'll get you to tell me from your perspective, what is this course about, and what are some of the conditions you treat in this Art of Mat course?
This Art of Mat, we had this in the can for 2 years. It was such a complex thing to film, and we had a lot of filming problems, but we endured, and we really love it. And it's a 16 CE course, which is home study, and also people who buy that course can get our e-learning version of it too, free. It's the very last step in our 210-hour Master Myoskeletal Therapist program, our MMT program. We got licensed, register mark through the government a few months ago from that, but it's just completed. We've been working on that for about 7 or 8 years now, and we're really excited about that. We have about 24 people that have completed the program, and we have about 100 people that are working on it, working their way toward Master Myoskeletal Therapist certification. This Art of Mat is kind of the final thing to put it all together. And we treat, in this video, this Art of Mat, we treat people with conditions such as thoracic outlet, as we saw in Dina, nocturnal arm numbness, low back pain on forward bending, those bending and twisting incidences that we see a lot. They lean down and can't come back up. Leg pain on sitting, had a person with some bad sciatica when they sat. Crooked spines, we see functional scoliosis and structural scoliosis, different kinds of how to treat even scoliosis that are fixed scoliosis, how to treat the functional component of those kinds of things. Neck cricks that refer into the arms, some nerve things that come off the neck, pelvic pain, breathing disorders, and chronic overuse sports injuries. Kind of pretty much sums it up.
Okay, so it's a broad range of conditions. And,
a lot of stuff, yeah.
And again, these are some difficult clients that have
yeah.
not that the clients are difficult pain issues.
Yes. Yeah.
Now, is this a course for people that want to know more about myoskeletal alignment techniques and that want to learn more about the approach? Is this a course that they should start with, or is there another course that you would suggest they start with?
No, I don't necessarily. They can start anywhere really. All of them pretty much have context so that they can follow, and depends on what kind of training they've had. But personally, I like them to start with my first course, which was released in 1998. First full home study course released in the United States, fully approved by everybody. Myoskeletal alignment techniques, posture, pain, and performance.
Okay.
It's foundational. Yeah, it's the foundational mat course, and it focuses on clients with chronic neck and low back pain. As A.T. Still used to say, learn to fix necks and backs, and you'll always have a full practice. And that's kind of what we, focus on in that series. Right now, if you sign up for my Technique Tuesday newsletter, which obviously is mailed out every Tuesday to 140,000 people, we have 25% discount on this posture pain performance course. So if they go to ericdalton.com and just sign up for the newsletter, they can get a 25% discount code to buy posture pain performance.
Okay, fantastic. Good to know. And I know just just recently, you've released, you're in the process of releasing a lot of your courses as e-courses online, as opposed to the manual and DVD format. So that's very exciting, and will make it accessible to a lot more people. So congratulations on getting your e-courses launched. And you also offer workshops, as well as you have a staff of trainers. Can you tell us a little bit about the workshops and where those might be happening?
Right. Personally, I'm only teaching one workshop a year, one USA workshop a year, and that is here in Oklahoma City, where I spend a lot of time. We're having our 6th annual Oklahoma City workshop the weekend just before the 4th of July, so people like to come and celebrate the 4th of July with us on the Riverwalk down here. It's a beautiful hotel downtown that sells out. It's already almost over half full. This year, I'm honored to have Tilda Chow teaching an afternoon segment on migraines and neurogenic headaches. So we have a bunch of other special educators joining us this year, including Erik Stevenson, Drew Freeman, Paul Kelly, of course, and the legendary and illustrious Erik Brown.
I'm excited to be there. It'll be fun. Yeah. So that'll be a fun event. And you also, well, really where I would like to come right now at this time of the year is Costa Rica.
Yeah, it's nice here today. No, but also our 19th annual, can't believe it, Pain Management in Paradise in Costa Rica workshop happens again the weekend following Thanksgiving every year, and it always sells out, so got to get in there soon too. Paul Kelly teaches a bunch of events each year, including Charlotte, North Carolina. Is it next weekend, March 10th and 11th, if that's next weekend? So you better get enrolled in that. And then also in Nashville, April 7th and 8th, I'm going to be assisting working the tables with Paul. We have a blast when I come. I'll be attending several of his workshops this year, assisting him. And we have other teachers that teach too. Aubrey Gowing in Ireland has just finished a course, and Nick Kress and several other teachers are teaching around the country, so check ericdalton.com for additional workshops that are coming to towns near you, cities near you.
Okay.
Countries.
Yeah, so I want to encourage our listeners, check out Erik's offerings, ericdalton.com. You'll find out about all the home study and e-courses that are available, as well as upcoming workshops, and highly encourage you to check those out and get to one of the workshops especially. They're very, very exciting. So thank you once again, Erik. Really appreciate your contributions to the profession. Really appreciate you being here at World Massage Conference with us. Once again, it's been a fantastic 11 years, and we wish you all the best with all your future endeavors.
Congratulations on that. 11 years. That's wonderful. Well, I'll miss it next year, but I know you guys have got a lot of other stuff you're doing, so we'll see you.
Yeah, I'll still be around. I'll be knocking on your door.
Thank you, guys. Thanks for attending this. Appreciate it. Love you guys.
Okay, have a great day.
All right.